Hey guys, welcome back. We're going to review Chapter 17 of Unit 5, talking about staffing needs and scheduling policies. So why is scheduling so difficult in nursing? It does not fit into a traditional business cycle, as you guys all know. Hospitals are open 24/7, not a 9 to 5 business. There is an erratic and unpredictable healthcare demand. You never know how many patients you're going to have. You could have a completely full unit. You may have some empty beds. That leads to staffing. You don't want to overstaff. You have high level expertise that is required 24/7. Stress of a job requires a balanced work recreation schedule, a reaction schedule, and staffing mix varies with acuity. So, depending on how your patients are, depends on how many nurses you'll need. So, staffing clerks, although many organizations now use staffing clerks and computers to assist with staffing, the overall responsibility of scheduling continues to be an important function of the first and middle level managers. Strengths and limitations of decentralized and centralized staffing. So for decentralized staffing, some strengths are manager retains greater control over unit staffing. Staff are able to take requests directly to their manager, and it provides greater autonomy and flexibility for the individual staff member. Some limitations that occur with decentralized staffing is that it can result in a more special pleading and arbitrary treatment of employees. It may not be cost effective for organizations since staffing needs are not viewed holistically, and it's more time consuming for the unit manager. Some strengths for centralized staffing is that it provides organization wide view of staffing needs, which encourages optimal utilization of staffing resources. Staffing policies tend to be employed more consistently and impartially. It's more cost effective than decentralized staffing, and it frees the mid level manager to complete other management functions, not having to focus on staffing. So, some limitations are that it provides less flexibility for the worker and may not account for a specific worker's desire or special needs. Managers may be less responsive to personal budget control and scheduling and staffing matters. Question 1, tell whether the statement is true or false. Staffing in a busy physician's office is performed by the unit manager. This is an example of an office managed using the decentralized model. True or false? That's true. The decentralized model staffing is often done by the unit manager, whereas under the centralized model, it is done at a central office, often by a computer. So staffing and decision making. It is important to remember that centralized and decentralized staffing is not synonymous with centralized and decentralized decision making. Fair and uniform staffing and scheduling policies must be written and communicated to all staff. Decentralized scheduling and staffing lead to increased autonomy and flexibility, but centralized staffing is fair to all employees because policies tend to be employed more consistently and impartially because you don't have that direct care manager making those decisions. Complying with staff mandates. Many states have imposed mandatory licensed staffing requirements. 12 states have addressed nurse staffing in hospital. California has imposed legislation to comply with minimum staffing ratios. Imposed staffing due to a patient care being affected. Common staffing and scheduling options in healthcare organizations. 10 to 12-hour shifts, premium pay for weekend work, part-time staffing pool for weekend shifts and holidays, cyclical staffing, which allows long-term knowledge of future work schedules because a set staffing pattern is repeated every few weeks. You can look at figure 17.1 that shows a master staffing pattern that repeats every 4 weeks. That's in chapter 17 of your book. Job sharing, allowing nurses to exchange hours for work among themselves and flex time. So use of supplemental staffing from outside registries and float pools, another thing that's common in staffing and scheduling options. Self-staffing and scheduling. Shift bidding, which allows nurses to bid for shifts rather than requiring mandatory overtime. And some scheduling alternatives include using agency nurses, having travel nurses, using flex time. So nurses can apply to work overtime and they get an extra, sometimes will get an extra pay for flexing up and getting more time. Self-scheduling, having float pools. This is where float staff must be able to perform in the core competencies of the unit they are floating to meet their legal and moral obligations as a caregiver. What are some of the advantages of an organization of using travel nurses? A, they can be in premium pay. B, they provide scheduling relief. C, they offer good continuity of care. Or D, all the above. It's B, they provide scheduling relief. Although travel or agency nurses can fill in during a scheduling emergency, their pay can be hard on the budget, and their continued use can compromise care continuity. So a formula for calculating nursing care hours per patient is to divide your nursing hours worked in 24 hours by your patient census. So you know that you've had how many nurses you've had, how many hours they've worked, divided by your patient census. Staffing by acuity is using a patient classification system. It's groupings of patients according to specific characteristics, so like disease processes, if they have wounds, if they're heavier patients, those kind of things. Hours of nursing care assigned to each patient classification, unique to a specific institution. It's constantly ongoing review, internal or external forces affecting the unit influence classification system. So PCS, the patient classification system, that's the critical indicator of PCS, uses broad indicators such as bathing, diet, intravenous fluids and medications, and positioning to categorize patient activities. To summarize tasks, the PCS requires the nurse to know the frequency of occurrence of specific activities, treatments, and procedures for each patient. At the national level, the use of PCS is a condition of participation in Medicare and is required by the Joint Commission for certification. A nurse manager notes how often a patient takes his medication to determine scheduling. This is an example of which of the following systems: critical indicator, PCS, summative PCF, or staffing by acuity. This is summative PCS. In this task, the patient classification looks at frequency of a specific activity, whereas critical indicator PCS uses broader, more general measures, staffing by acuity groups patients according to specific characteristics. The relationship between staffing and quality care is staffing mixes, staffing ratios, and the number of staff. Effect of decreased hours. A review of the literature consistently and overwhelmingly demonstrates that RN hours decrease in NCH and PPD, adverse patient outcomes increase. This includes increased medication errors, patient falls, and decreased patient satisfaction with pain management. This all happens when you have a decrease in nursing hours. General diversity in nursing. The generation, you have the silent generation, and this is those that are between 1925 and 1942. You have the baby boomer generation, which is between 1943 to early 1960s. And you have Generation X, which is between the early 1960s to 1980s. And then Generation Y, which is 1980 to present, also known as the millennials. Well, millennials only go up to, I think, into 2000s. And then there's Generation Z. The silent generation comprises people born from A, 1943 to early 1960, B, 1965 to 1975, C, 1960 to 1980, D, 1917 to 1925, or E, none of the above? And the answer is E, none of the above. And the rationale is because the silent generation refers to those born between 1925 and 1942. Closed unit staffing. Closed unit staffing occurs when the staff members on a unit make a commitment to cover all absences and needed extra help themselves in return for not being pulled from the unit in times of low census. Criteria to meet when handling understaffing issues. Decisions must meet state and federal labor laws and organizational policies. Staff must not be demoralized or excessively fatigued by frequent or extended overtime requests. Patient care must not be jeopardized. So mandatory overtime is where employees are forced to work additional shifts, often under threat of patient abandonment. Say if they don't work that shift, that they will be turned in for patient abandonment. Although mandatory overtime is neither efficient nor effective in the long term, it has an even more devastating short-term impact in terms of staff participation of lack of control and a perception of lack of control and its subsequent impact on mood, motivation, and productivity. I have seen this where you have mandatory overtime. I've seen it in other facilities, and it does cause a huge impact on staff morale and the negativity that spurs within the units. The effect of mandatory overtime are most detrimental in the A, short term, or B, long term. This is A, short term. Although mandatory overtime has negative long-term consequences, the immediate effects on staff's mood, motivation, and productivity are even more worrisome. So organizational staffing policies. You need policies that address sick leave, vaccinations, holidays, call-offs, furlough census, on-call pay, and tardiness and absenteeism. Fiscal accountability. This is to an organization for staffing is not incompatible with ethical accountability to patients and staff. It should be possible to stay within a staffing budget and meet the needs of patients and staff. And that is it for chapter 17. Thanks, guys.